Good day. My name is Ed Copping, and I'm a member of the Users Committee of the CHUS Hospital Centre Hotel Dieu and Fleury Mall sites. One of our mandates is to keep our users informed of their rights and privileges. As such, today we have with us Dr. Carl Bromwich, a specialist in palliative care, and Marie Truesdale, a member of our committee who is also a retired nurse and holds a master's degree in health law.
We on the Users Committee have found that there's a great deal of confusion around end-of-life planning and what care and services are available. We have collected questions from the population and have divided them into 3 separate periods of life. Since we never know what life has in store for us, we need to think about end-of-life priorities long before we're ill. But to do so, we must have a good idea of what options there are that are available to us.
My first question is for Marie Truesdale. Even though I am presently in good health, should I take action now to ensure that my end-of-life wishes and values are respected if something happens to me and I no longer have the capacity to express my wishes?
It's very important to take the opportunity to express your wishes ahead of time while you're able to do so. 2 legal processes are available to us that really help us to have our wishes respected. One of them is the Advanced Medical Directives, or the AMD as we call it, and the other is the Protection Mandate.
Marie, what is an AMD?
Well, what this involves is permitting a person to determine that the care that they would consent to or refuse to consent to in 3 specific situations. One being at the end of life, when a person is suffering from an incurable disease and there's really they're at the end of their life. Another situation would be the irreversible coma, such as when a person has a brain injury and there's no hope of improving the situation. And the third situation is when a person suffers from an irreversible cognitive impairment, such as when someone is suffering from advanced dementia. Now, included in Advanced Medical Directives is a form, and in this form, it permits the person to register what treatments it would consent to or refuse to. And there are 5 of them. The first one is cardiopulmonary resuscitation. And that's the same thing as this is the intervention that's carried out when a person has a heart attack, or cardiac arrest as we normally call it. The second is assisted ventilation. This is a medical intervention with equipment that helps the person to breathe should they stop breathing. A third intervention is dialysis, and this is another medical intervention where the blood is no longer cleaned by the kidneys. Then we have forced feeding. This is when the person is refusing to eat, but is fed nevertheless, either forcefully or through a feeding tube, or it could be through intravenous. And the 5th one is forced hydration. Again, the person's refusing to drink. This also includes forced or providing hydration through arterial or venous intravenous's.
I would just add, it's a nuance, but it's not just when someone refuses, but also when they're unable. So someone who's unable to eat or drink, and they're being supported artificially. Those are other ways to think about.
Yes, I would agree with Dr. Bromwich.
Very interesting. And how would we get such a document?
How do we get it? Well, there are three ways. One is you can go online to the Régie d'assurance maladie de Québec. You can also do this with Click Secure, which is another mechanism that's available to us. You can call the Régie d'assurance maladie de Québec, and there's a 1-800 number that can be obtained. And if you're doing this process, going through this process with your notary, then the notary can assume the responsibility for making sure that the Régie d'assurance maladie de Québec has a copy of these directives.
We've had many questions regarding the protection mandate or mandate in case of incapacity. Ms. Truesdale, can you shed some light on this subject?
Okay, well, the mandate in case of inaptitude is really it's a document. It's a document that the patient fills out, and in the document they express what their wishes are, and they designate a person or persons to speak for them and in terms of their property when they're no longer able to do so. Now, the protection mandate has to be activated in order for it to become legal. A judge has to certify it or homologate it, as the process is legally referred to. But this is only after your incapacity has been declared following a medical evaluation.
And why is this document so important?
Why is it important to have a document? Well, it's an excellent tool for writing down your wishes. And you can be as explicit as possible, but there are many situations that occur while a person is ill. Many situations really that the advanced medical directives don't cover. And the healthcare professionals, they have to be able to get a consent or a refusal to consent from someone. In the mandate, the person or persons who have been designated are people who usually really understand the wishes of the person who's preparing the mandate. They're speaking on their behalf, and actually they must speak on the behalf of the person who's made the mandate. This should be someone that the person trusts, absolutely. So, of course, they have no legal power to intervene and consent or refuse to consent unless the mandate has been certified or homologated. But sometimes everything happens quickly and there's no time to go through the whole legal process. If this is the situation, then the healthcare professionals would refer to a family member or a close friend of the person, and that would be according to what is stated in the Civil Code of Quebec.
Yeah, I would just add that in practical application in the hospital for end-of-life care, we actually very, very rarely rely on a formal mandate certified by a judge. As Marie suggested, things are often happening too quickly, and we rely on a family member if the patient is incapacitated or unable to make decisions for themselves. And I think the thing to underline here is that the Advanced Medical Directive and the mandate are important legal tools, but the most important thing that a person can do is to make sure that their loved ones understand how they see things and what they would want. It's not so much about whether you would want this medical treatment or that medical treatment. It's that they understand what's important to you. And that way, you know, when the physician is proposing a therapy, they can just say, well, is that going to help Dad get back to a state where he can climb Mount Kilimanjaro in the spring, or watch the Canadians win the Stanley Cup, or something like that. And if the doctor says, well, no, that those aren't realistic objectives given the situation, then the family member can say, well, that's not what he would want then. So really the those discussions, I would say, are every bit as important, if not more important, than the actual legal tools that we have access to, because we're much more prone to rely on a family member. The exception would be in a situation where there's a family conflict.
Yes.
And then it's very nice to have a legal document to support.
Exactly. And sometimes when more than one mandatory has been designated and there's a dispute between the two. And then, so that's another complication that could happen.
So if I understand correctly, the AMD and the protection mandate both require witnesses. Who should I pick as witnesses?
Okay, well, first of all, we must say that if the process is being carried out by a notary, then 2 witnesses are not required. But it's having a discussion with the people who are going to speak for you, speak on your behalf. It's important that you really do have a chance to talk about your wishes, to explain your values. It's an opportunity to talk about a subject, that's normally not talked about.
What would arise if I have no family or friends?
Well, if you have absolutely no one you could trust, no one who you think would really respect your values and your wishes, it's better to not have any document at all. In these situations, the healthcare professionals, they would make sure that the social service professionals have a chance to know about the situation, and they would take measures to make sure that you are represented and protected.
How would caregivers be informed of these advanced medical directives?
The first thing, it's important that you give a copy to the people you care about. Could be the witnesses, of course, who have signed, for instance, the advanced medical directives and the mandatory. Your physician should have a copy. And it could also be left in the archives of the hospital where you think that you would be treated. Physicians who are caring for individuals at the end of their life, they also have access to the Régie d'assurance maladie de Québec, where your original advanced medical directives would be archived.
Dr. Bromwich, my next question is for you. I've just been diagnosed with a disease that cannot be cured. What should I do to ensure that my wishes and values are respected?
Well, we've already heard about 2 legal tools that you can use to make sure that your wishes and values are respected. I would underline again that the most important thing you can do is to discuss these things with your loved ones and with your treating physician. There's another tool called the Objectives of Care, which can also be useful in this context. It helps doctors in the context of a patient who's not any longer able to take decisions for himself to sort of guide their decision-making. So the Objectives of Care in the new model are prolongation, balance, and comfort. So prolongation is a level of care where the principal objective is to prolong life. And some would say at any price. In other words, the patient is willing to put up with considerable discomfort in order to have his life prolonged. The balance is when someone wants to prolong their life, but they're prepared to set certain limits with respect to what kind of care they would accept. So someone, for example, who would want to continue having their heart failure treated or would want to continue chemotherapy, but in the event of a cardiac arrest would not want cardiopulmonary resuscitation, or in the event of respiratory failure would not want to go to the intensive care unit and be intubated. That would be an example of a balanced approach to care. And finally, there's comfort care, where the patient's principal wish is for comfort, and they're not any longer interested in interventions that are liable to prolong their life. As a part of the same form, there's also a discussion about cardiopulmonary resuscitation and intubation. So a patient in the same objectives of care form can say whether, yes, they would accept those treatments or no, they would not accept them in the event that they were medically necessary.
In talking about goals of care and cardiopulmonary resuscitation, can you explain to us what this would involve?
Well, cardiopulmonary resuscitation is an intervention that is performed when someone's heart stops. So it involves pumping on the chest, giving different drugs to try and get the heart restarted again. Intubation, as Marie explained earlier, is using a machine to breathe for a patient when they're no longer able to breathe for themselves. So they're two pretty extreme interventions. And they're not always successful. Cardiopulmonary resuscitation, depending on the situation, can be a success. Someone's resuscitated right away if if they have a cardiac arrest in the emergency room, for example. In other situations, it's much less likely to be successful. And so when we discuss that with patients, it's really important for them to understand that it's not like TV. The context determines what the likelihood of a good outcome is. And I say good outcome because sometimes we can successfully resuscitate the heart. That is to say, someone whose heart hasn't been beating for 10 minutes, the heart can be resuscitated. That is to say, it'll start beating again. But the organs that it was supplying with blood cannot necessarily be resuscitated. And the brain is the most oxygen-sensitive organ. And when the brain has an injury, it doesn't recover well. So it's important for patients to understand the potential outcomes when they're considering an aggressive intervention like that.
So if I understand correctly, following a discussion with my health professional, I should have a copy of a document that specifies my goals of care and resuscitation decisions. What should I do with this document?
Well, as with the other documents, the most important thing to do with it is to make sure that your loved ones have a copy of it so that they can provide it in the event that you're not able to take decisions for yourself. Remember, all of these documents are backup plans. As long as a patient is able to discuss something with the doctor, nobody even looks at those papers. The intervention at the moment with the patient takes priority. But in the event that a patient loses the ability to decide, then we rely on those papers. So loved ones should have a copy. Your physician should have a copy. There should be a copy in your hospital chart. And especially for someone who lives alone, there's no guarantee that it's effective. But having a copy actually posted on your fridge or on the wall in the event that someone comes in and finds you in extremis, the ambulance people who show up are obliged to provide full support unless they have a document that says that you've discussed this with a doctor and that you would not want to be resuscitated.
Dr. Bromwich, you have provided helpful information that applies to when I am receiving care and treatment. My illness has now progressed and my death is imminent. What are the options that may now be available to me?
Well, hopefully your treating physician has been applying palliative care for some time now. Many people see palliative care as being end-of-life care, that it's applied when death is imminent. In fact, palliative care is appropriate and should be applied from the time someone is diagnosed with an incurable illness until they reach the end of life. So for the sake of our conversation, I'll assume that the person in question has had good palliative care up until now. And what I would say is any family member, any patient who isn't getting palliative care, hasn't heard the words palliative care, should feel free at the time of a diagnosis to request an intervention with palliative care. Many primary care physicians, many specialists actually provide good palliative care without using those words. But when in doubt, it's okay to ask for a palliative care consultation. So now, in spite of good palliative care, you're approaching the end of life, and it's important to understand what your options are. So one option is to continue pursuing whatever care you were getting up until that point. That's a discussion that you should have with your treating physician. What I always tell patients is that they are the captain of their own ship. The physician might provide direction, hopefully will provide direction, but the direction needs to make sense to the captain. So one option is to continue pursuing whatever treatments you were getting for as long as the treating physician is prepared to offer them. Another option, however, for patients who are suffering or are tired of, or their quality of life has gotten so poor that they don't wish to prolong their life anymore, is to stop those treatments. And in fact, it's possible not only to stop those treatments, but to stop all treatments that may prolong life. So this is a change from sort of when we were talking about objectives of care, attempting to prolong life. Then you reach this equilibrium between prolongation and comfort. And now we're talking about really focusing on comfort. And when I discuss comfort care with a patient, I always say that one of the options is to take the foot off the brake. You know, someone who's dying doesn't need their antihypertensive medication anymore. They don't need to be controlling their cholesterol anymore. It's shocking how many times I see patients who are literally within days of dying who are still taking their Lipitor for their cholesterol. So for many patients, that's enough. Just taking the foot off the brake, having adequate palliative care to ensure comfort, and arriving at a natural death. For some patients, good palliative care isn't enough. And if their suffering is unresolved and extreme, in spite of palliative care, then they could access what's called continuous palliative sedation, which is a treatment whereby we render the patient unconscious, deeply unconscious, in an effort to completely extinguish their suffering. Obviously, the price to pay is that they lose their ability to interact with their loved ones. So it's an extreme measure that's only used at the very end of life. It's important to note that palliative sedation, the objective is to relieve suffering and to render the patient unconscious. As a means of doing so, it is not to shorten life. Some patients, the idea of being put to sleep and then lingering for a week or 10 days in an unconscious state is unacceptable. And for those patients, medical aid in dying is also an option. So a person who is at the end of life and is overwhelmed with anxiety or physical suffering can make a request for medical aid in dying. And that's a way of not just taking your foot off the brake, but actually exiting prematurely, some would say.
Now, what types of care can I receive and how will I get them?
Well, the way you get them is by discussing things with your treating physician and making sure that your family is aware of what you would want in the event that you're no longer able to discuss things with your physician. And again, there's legal forms that are necessary for someone who wants to take the step of requesting medical aid in dying. What I tell my patients is that contemplating medical aid in dying is something that can go on for months or years, but when a patient decides they actually want medical aid in dying, they need to make a formal request. They need to get a healthcare professional and say, I want to sign a request for medical aid in dying. Those words are very difficult to ignore. Saying things like, oh, I can't bear it anymore, or oh, I wish it would be over, or I wish God would come and get me. whatever else it is, those aren't specific requests for medical aid in dying, and they won't be responded to as such. Many physicians are reluctant to name medical aid in dying to patients who are using euphemisms like that. It's not up to us to suggest medical aid in dying. I think it's on the menu of patients who are suffering at the end of life, and people need to be aware of it. But it's the patient who bears the responsibility for making a request. Similarly, continuous palliative sedation requires a direct request, either from the patient or from a family member. That's an important nuance between continuous palliative sedation and medical aid in dying, is that a person who has lost capacity cannot request medical aid in dying. A family member can't do it on their behalf, even if they had expressed wishes otherwise beforehand. But continuous palliative sedation can be requested by a family member if it's concordant with the wishes previously expressed by a patient.
As of October 30th, 2024, it will be possible for those with a neurocognitive disease to make an advance request for medical assistance in dying. Dr. Bromwich, can you give us a little more information on this subject?
Yes, I can try. It's new, and it's certainly more complicated than making a request for medical aid in dying. In French, they say contemporain, but a request for medical aid in dying for a problem that exists right now. So someone who gets a diagnosis of dementia and who is at risk of losing capacity can now make a request for medical aid in dying in anticipation of that loss of capacity. Because remember, I said that prior to this adjustment to the law, if someone lost capacity, they could no longer make a request. Since 2021, I guess, when they added the clause of medical aid in dying for patients whose natural death was not reasonably foreseeable, patients with dementia could request medical aid in dying, have been able to since 2021. The difference is that now they can request it in anticipation of a loss of capacity. So it permits them to live longer with, say, less and less capacity if that was their wish, because in the previous situation, patients had to maintain their capacity to decide right up until the time that they got medical aid in dying. The difference is that, so in this situation, someone has to have symptomatic dementia. They need to make a list of what they would consider to be intolerable suffering. There need to be 2 witnesses to the list. There need to be, I forget what they're called, but sort of advocates who can inform the doctor if the patient arrives at a place where they're no longer able to decide, and they're also suffering from these different things that the patient has previously listed. In that case, if the advanced request has been accepted, a physician will be informed, another evaluation will take place, and if the physician determines that the patient is suffering intolerably, then medical aid in dying can be applied. And it's a complicated situation. That one of the things that worries many people is the notion of someone who's happily demented. So someone who's lost their capacity, who's no longer, in an extreme example, say no longer able to recognize family or friends, no longer able to care for themselves in any way, but they're smiling, they seem happy. By the way the law is written now, those patients will not they won't get medical aid in dying, because at the time of the physician's evaluation, he won't be able to say they're suffering intolerably, notwithstanding whatever they may have written on their list ahead of time. So it's a much more complicated process than the straightforward medical aid in dying.
Very interesting. Marie, we've talked about the different types of end-of-life care that are possible. Can you please tell us where we will receive this care?
Well, it's certainly offered in more situations than just in a hospital. The entrance criteria really depend on the center that will be receiving these people who are needing this care. For example, home is one area. Now, multidisciplinary palliative care teams can go into the person's home. They can also provide care, say, within a long-term care establishment. It really is where the person considers home to be. There are also palliative care services offered in any unit within the hospital. There are palliative care workers who will offer the team's assistance in deciding how to give the care. Now, some hospitals have palliative care units. It depends on whether the hospital has decided to set up one of these units. Within the unit, there'll be a multidisciplinary team providing the care. So we have the home, we have any unit, we have a specific palliative care unit, and then we also have palliative care centers. And these specific palliative care centers decide themselves the access criteria. So there are, this palliative care is offered in several different settings.
Dr. Bromwich, Ms. Treesdale, I'd like to thank you for all of the valuable information you've given us today. We therefore invite people to plan ahead by obtaining information from their professional, to be proactive and to involve future caregivers and legal representatives in the planning.